بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening, everyone, and welcome to today's National Heart Center EP webinar on advances in cardiac implantable device therapy. We are thrilled to have you join us for what promises to be an insightful webinar. Over the past decade, the field of cardiac implantable devices has witnessed remarkable progress. These devices are transforming the way we manage our patients with arrhythmia, heart failure, sudden cardiac death, from ordinary pacemakers and defibrillators to the cutting-edge leadless pacemakers, subcutaneous implantable defibrillators, and extravascular ICDs. These technologies and the evolution of the technologies is reshaping outcomes and improving survival. Today, we are joined by an expert in the field of cardiac electrophysiology in the kingdom to share their insights and views about the advances in cardiac implantable device therapy. Before we begin, if you have questions, please submit the questions in the Q&A panel. We will have Q&A at the end of the presentations, inshallah. Now, let's dive in and let me welcome our first speaker, Dr. Abdullah Shehri. He is an electrophysiologist at King Faisal Medical City, Abha. We are honored to have him as newly joining the EP group in the kingdom. And we are eager to hear from him about device-related infections, how to prevent, how to recognize, and how to manage. Dr. Abdullah?
بسم الله السلام عليكم ورحمة الله وبركاته. الله يسعد مساكم. Thank you, Dr. Bender, for the introduction. Thank you, Dr. Fahad Mahmadi, for invitation and the arrangement. It's pleasure to be with you today and having my first presentation with the EP group. Just for time's sake, I'm gonna kick off my talk today. I'm gonna talk about device-related infection, how to recognize, manage, and prevent. And these are my objectives for my talk, scope of the problem, how to, it's very important to take your attention to understand the prevalence, how important to recognize this issue, how to diagnose, how to manage and prevent cardiac device infection. So let me start and kick off with the scope of the problem. So what is cardiac device infection? Cardiac device infection are microorganisms that can colonize and attach to the device. It can be bacterial, yeast, fungal, or fungal infection. These infection can start at the initial implantation of the device, at the time we implanting in the table. However, this infection can also seeding in the pocket and localize there, or it can also go to the lead. There is or will be also another source of infection, that's hematogenous seeding from other side of the body that can go and attach to the cardiac device, and we end up with a cardiac device infection. Cardiac device infection is very important to recognize, and there is a lot of many study that showing the rate of this issue getting worse or increasing with the years. And that's mainly because we start to implant more and more devices, and we start to deal more with more patients who had more complex issue, and we're gonna see that in coming a few slides as well. Um, there is a lot of data, mainly in the US. One of the data they showing that they implanting around 250,000 devices per year, and the number of having an infection for these cardiac devices 1 to 2%. For new implanted device, for subsequent procedure can reach to up to 5%, and meaning for subsequent they meant the redo procedures, pulse generator changes, upgraded device procedures. These can carry a higher risk of infection, and these numbers of infection are globally acceptable. This diagram from a rabbit a trial that's showing that device infection can happen early, and also it can happen very late. So it does not mandatory to happen in the first few days or weeks. We can see cardiac device infection happen many after many months or after years or so. Another diagram from the same trial showing how risky these events of infection in the device. It can carry and mortality that can go up to 23% for patient who's having a device from the onset of diagnosis. So this is a nice a trial, another nice trial showing the incidence and showing how subsequent procedure like an redo or another procedure, when we open the pocket again, we carry the risk almost double from the initial time of the procedure. So double risk, that's something we need to keep it in our mind as an EP interventionist. In Saudi Arabia, I couldn't actually have an access to a lot of data for our incidents. It's only this study that was conducted in King Abdulaziz Cardiac Center between 2016 2019. They did a study for almost a 612 patient, and the incidence of having of for people who have a device infection was 5.6, a quite high number. But however, I think we need more data in our centers, and this is an area of improvement that we can work on later. This is the latest consensus document for cardiac device infection that we released in European, and it was also endorsed by Heart Arrhythmia Society. And my mainly talk and guidelines coming from this document. I'm sorry for this busy slide, but it's very important to recognize the risk that can lead your patient to have a device infection. And they divide it here in this schedule to a patient-related factor, a procedure-related factors, or device-related factors. The most one of the most that important that I can see, the end-stage renal disease, diabetes patient, people who's having heparin bridging, carrying more risk of infection, as we all know. Hematoma, one of the major risk for having a cardiac device, and the more complicated device, the more risk. So more lead, more complex CRTs, and so on, the more risk of infection. Uh, Here is another study showing the numbers of having cardiac device infection is growing with the years, but in the other diagram, it's showing what type of patient you are dealing with. So more people having a heart failure, more people having renal infection. So we are dealing more and more with more complex patients, and that can explain. Or at least be one of the factor why we still having a high number of cardiac device infection. And also the age also consider one of the factors. Um, Again, I'm a fan for a local study. So another study had conducted by Dr. Naim Al-Shaib, Dr. Ahmed Faqih, Dr. Khadija Maghrabi. I think it was done in microbiology lab in King Abdulaziz University. The study, it was a study they compare people who had a cardiac device infection to people who did not, and they came up with the result that this risk factors in our area carrying a risk will lead our patient to having more high risk of infection. What about the pathogenesis? So Staph aureus, as majority of us is know, still are leading the microorganism for causing a cardiac device infection. However, we should not ignore other organism which can also do an infection. This diagram, just for sake of time, I'm going a little bit fast. Sorry for that, but this diagram. Also showing the percentage of microorganism and distribution for it to cause a device infection. Another study also from our area and showing the same results as globally. Staph aureus still the major common organism for cardiac device infection. So the second part of my lecture, how we should diagnose and what tool we should use. For diagnosis, I'm going to talk about three parts: the diagnosis for clinical assessment, microbiology, and imaging. So For clinical assessment, we can divide the cardiac device infection to a pocket infection or lead infections and more complicated. For assessment clinically, we should pay attention and examine the area of the device very well. It can be started from, it can be a superficial at the incision area infection involve only the skin or subcutaneous. And for those patients, usually we treat them with antibiotic with a high being alert and close follow-up for those patients to avoid more complex procedure. Sorry, complex diagnosis. So it can get more worse. We can see more erosion of the leads, sinus tract with a pus discharge. It can go further to necrotizing the tissue. We can see device eroding, and when we do extraction, we see sometimes a calcification and fibrosis on the lead in higher risk patients. So it can go from easy to very hard and challenging case. Uh, what criteria we are using for diagnosis cardiac device infection is the same criteria for infective endocarditis. So diagnosis depend and rely on combination of major and minor criteria, and I'm not gonna spend a lot of time on that one. We're gonna move to microbiology diagnosis. Just an important point. We need to remember that we need to take a sample before we start with the antibiotic. It's recommended to get at least 2 to 3 sets. And we should always remember that only 30 to 50% of cardiac device infection end up with a positive culture. So negative culture cannot rule out ongoing infection. If we have opened the pocket, then we need to take a sample, but taking a sample was recommended to avoid in the guidelines because it might cause more harm and open the wound, and also it will give you a misleading result, and because the contamination from the skin and the flora. Taking a tissue sample and from the lead itself or device also is a class 1 indication. So this is the class 1 indication in the European guidelines. The green heart is class 1, yellow heart is class 2A, as we all know. The point that I want to mention, the PCT is also a tool that we can send for if we're still having a high suspicion of cardiac device infection. Moving to the image, transthoracic echo absolutely is a class 1 indication, and also a TEE, which have a high sensitivity and high specificity. But if we still having a high suspicion and those two came negative, then we have a class 1 indication for using a nuclear scan. And in the next slide, we're gonna see how it can help. CT scan also one of the tool that can help us to see the vascular complication of cardiac device infection. In this slide, nice image was published in this study showing how nuclear scan can help us. So in picture A, we can see infected device, infected lead, and pulmonary septic emboli. In picture B, a patient having infected lead, no device infection. Picture C showing pocket infection, but no lead infection. And picture D, a patient who has a mass on the lead, suspicion of thrombus, but PET scan rule out that out, and patient found to have ended by having only a thrombus, an infection, not an infection. So this is the class, the recommendation from guidelines. The thing that get my attention is an ICE, now it's in class 2A. For an expert people who's using ICE, it can help if transthoracic and TE is negative and you still having high suspicion for an infective endocarditis. How we should manage. So guidelines say it clearly: antibiotic and take the device out. Device should be taken out with no question if there is a pocket infection or systemic infection. Back to the antibiotics. The course of antibiotic can extend from 2 weeks to up to 6 weeks, depend on where is the localization of the infection. Is it only pocket? Is systemic? Is it involving the heart? valve disease, and etc. Removing device, as I said, it's class one indication. And following slides, I'm gonna show you why it's very important. So in this picture, five study was studying people who having cardiac device infection and who had a cardiac who had a removal, and how a complete device removal and partial systemic removal or medical treatment only. And those who did not have a removal, they have a relapse and recurrent of infection. Those who did not, who had a removal, they carry a better prognosis. In this study, it show a failure of conservative management for people who had a cardiac device infection, and with time, they try to just keep them on antibiotic. However, it's failed, and those patients end up with a readmission, and third of them had an explantation by the end. Another data analysis was done for a patient. It was multinational data. People who have a device removal carry a much better a survival rate comparing to those who did not. So taking device out is very important, but when should we take it early or later? And this study can answer our question. And in this study, they had a three group of people who have a cardiac device infection. The black line, people who had not, they didn't remove their device. The blue one, they removed their device, but a little after 7 days. And those who the gray is they took their device in the first week of diagnosis. And as you can see here, the better outcome for people who's taking their device earlier. Another study showing the same same results. So first week, better mortality, better less side effect and adverse effect.
For 1 minute, please.
Sure, I'm gonna try to finish up. So for cost, people who are having cardiac device infection carry they carry cost effect for on the health system, and taking and the majority of that from readmission and hospitalization. This algorithm suggested in the guidelines how we deal with it, and I mentioned it through my previous slide. And so post extraction management, we should have some consideration if the patient is dependent or not, what to do with if he had a line, when to do re-implant and what side. All of these consideration need to be taken. This study just show if patient having cardiac device and valve, a mechanical valve, should we remove them both? And the answer was showing taking device only, showing good result, and keeping the valve. So it's not an excuse for people who's having a device and mechanical valve just to keep the device because you're having also a mechanical valve. Last part, how to prevent. I divided into, based on the guidelines, pre-procedure, we should carry this important point in consideration, giving antibiotics for patients having risk based on the PATET score. As majority of us know this famous trial, which they carry, they describe a point for people who's having a higher risk of having device infection, and they give them more antibiotic. The PADET score, actually it was negative when they comparing more aggressive antibiotic to the group who having only cefazolin. However, this was a subgroup analysis and suggestion for people who's having more high risk. During the procedure, these recommendations are an important to follow. And rabbit study also was positive for using during for patient who is carrying a risk, using the Medtronic envelope as an protective procedure. Post procedure measurement. Remember, we give patient antibiotics if needed, and they carry higher risk and in relapse, we'll try to avoid hematoma. Another solution for people having high risk, we remember a leadless and subcutaneous ICD, one of the important tools. My conclusion is just remember, increasing in the number of cardiac device infections is very important to recognize a serious issue. We know what is the common pathogen, and we need to treat it very well with the antibiotic and consider extraction and refer it to a specialized intervention electrophysiologist. Thank you.
Thank you very much, Dr. Abdullah, for interesting talk. We will move now to the second talk by Dr. Salman Ghazni, who's an experienced cardiac electrophysiologist at Medina Cardiac Center, and he will talk to us about leadless pacemaker. Dr. Salman?
Assalamu alaikum. Good evening, everyone. Thank you for inviting me, and thank you, Dr. Bandar, for your introduction. Okay, so today, just a second. You can see my slides.
Yes, we see the slide, but it's not moving.
Uh-huh. Just a second. Stop sharing. This is moving now, right?
Yeah, it is moving. Yes.
Okay, so today we are discussing the indications, clinical data, and the future of the leadless pacing. So I have no disclosures. Today, the objective of our talk is to review the trials regarding the leadless pacemaker and to identify the indication, what are the indications for the implantation of the leadless pacemakers, and what is the future of the leadless pacemaker. Actually, I took my talk from this comprehensive review, which was recently published in 2025 regarding in the European Society of Cardiology regarding the leadless pacing. So let's go back to the history. Actually, we have four types of the leadless pacemaker. The first one is the Abbott leadless pacemaker, which is called an autism. The second one is Micra. The third one is Aware. And we have Empower, which is the Boston leadless pacemaker, which is still under trials. So nanotism is the first leadless pacemaker, which was first implanted in 2012, and actually 1,400 devices were implanted all over the world. And the implantation is stopped in 2016 due to early battery depletion, and it withdrawn from the market. And the length of this leadless pacemaker is around 42 millimeter. Then we have a Micra device, which is from Medtronic. It is first implanted in December 2013, and up till now, more than 200,000 devices implanted since then worldwide. It's a very small size as compared to the RV volume, which is less than 2%, and 3 micra can be implanted in the RV without device-to-device interaction. And the length of this device is 26 millimeter, which is lesser than the first device, which is nanostil. The third device is Aware, which is available in the market, and it introduced in 2022. And the length of this device is 38 millimeter, which is more than the Micra device. And according to them, the battery longevity is 17 years, but it needs further studies to basically prove that this battery longevity is still there or not. And they also have the atrial device, which is the leadless device, also available in Abbott device, which is Aware. So let's first of all regarding the implantation. So when we implant the leadless pacemaker, what is the ideal location? According to this article, which is published by the Christophe in the Journal of Educational Study and Heart Rhythm Society, and it shows that the narrowest space QRS complex was measured at the mid RV septum and the high RV septum compared with the apical septum. So if we try to put the leadless pacemaker at the mid septum versus higher septum, we will get more narrow QRS as compared to the apical septum. Now, this is another article which was published in the European Heart Journal in 2015, and it basically tell the early performance of the leadless cardiac pacemaker, which is the Micra transcatheter pacing device, and it was published in 2015. And it shows around 140 patients implanted from 11 different countries with a successful implantation of procedure in all patients. Out of them, 59% device was successfully implanted at the first attempt, like they went into the RV and they implanted in the first attempt with great thresholds, impedance, and sensing. And The rest of the 48% patients needs readjustments. During the 3-month follow-up of the first implantation registry, which is published in 2015, it shows 30 adverse events, which occurred in 26 patients and consisting of 9 cases of arrhythmias, 7 events as device placement site, and 11 events at the groin puncture site. Anyhow, this was like initial days of the microimplantation or the leadless pacemaker implantation. Then we move forward. There is another article which was published in the New England Journal of Medicine in 2016, and it shows the risk of complications are decreased significantly by decreased lower by 4%. So the only complications is thrombosis, which is embolism and thrombosis, which could be deep in thrombosis from the puncture side, or pulmonary embolism or pulmonary thrombosis because of the bigger sheath if they are not using heparin, which is around 0.7%. And the cardiac injury, which is perforation and tamponade, is 1.6%, and overall complication is 4%. But this was like early days in 2016, but it is significantly reduced as compared to the first study, which was published in 2015. Let's move forward to this journey. The other article, which was published in Journal of Arrhythmia and Heart Rhythm Society, the first article, which was published in the Heart Rhythm, is 2018, and the other one in 2023, which basically shows the patient profile and the performance over the time, and it's a real-world setting leadless pacemaker study. It basically shows in the Heart Rhythm, which was published in 2018, that total complication reduced to 1% to 2.2%, which was initially was 36%, then reduced to 4%, and now it reduced to 2%. And the perforation chances with the micro device is around 0.4%, which is very minimal. The other one is infection, which includes hematoma infection, like on the excess site, or abdominal wall infection, or the sepsis is around 0.06%. So with this study, they conclude that 63% reduction in complication compared to the transvenous pacing. Actually, they compared this with the normal conventional pacemaker, and they found that with the leadless pacemaker, there is a reduction of 63% in complications. As we move forward, there is an article which is published in the Heart Rhythm Society, which is basically telling us the performance of the micra transcatheter pacemaker in the real world setting as compared to the transvenous pacing. It basically shows that the mean pacing capture threshold was 0.6% from the implantation till the 18 months follow-up. So if you start and you see this graph, this is pretty steady graph, which showing the stable threshold throughout the 18 months. And another one, impedance is also stable, and also the sensing was stable throughout 18 months, which shows that how stable is the device once it's implanted properly in the right place. We have actually landmark trials of these three leadless pacemaker. The first trial was leadless 2, which is nanostem device. The micro device has 3 trials, which is IDEA, EMEA, and the PAR, which are the registry. And these basically 3 trials, if you combine, it includes around 2,600 patients. And the rate of complication is reduced from 4 to 3.6, and the last one is 2.7% overall. As we move forward, it was initially the single chamber microventricular device. Then they introduced another one, which is AV device to give the AV synchrony. And the AV synchrony is basically coming from the atrial contraction. Basically, the device has the capability to sense the atrial contraction using the accelerometer and may provide a signal for the AV synchrony. And it was proved by the 2 trials, which is Marvel and the MAS2 trials, and it shows a good AV synchrony. But the only drawback is that if the patient has heart rate of above 100 beats per minute or diastolic dysfunction, then it will leading to the lack of the appropriate sensing of the atrial contraction, and the device switch its mode to VVI, and we can lose the AV synchrony. So these basically the selection of the device is very important in the patients. If you choose a young patient and he needs higher rate, then he will not get AV synchrony with this device. But if you choose a patient who is older, doesn't have that much mobility, and we can put this device for the backup pacing, then it's very nice, and it can go to the AV synchrony if the heart rate is around less than 100 beats per minute, or has a normal LV function, or there is no diastolic dysfunction. Let's move forward regarding the outcomes of systemic infections. As Dr. Abdullah already discussed about the patients who has a CID infections, And once we remove the CID, we can put the leadless pacemakers or leadless plus subcutaneous ICD. So the risk of the infection in those patients who already infected with the CID device is very less. And this study was published in the Pacing and the Clinical Electrophysiology Journal. They include around 2,500 patients, and they saw that there was no device extraction for the infection of the leadless device in the patients who already were infected and successfully explanted the old device. And why it's so? Because if you see this autopsy, the biopsy of the heart, the device is completely encapsulated inside the heart within like few months. Once it's encapsulated completely inside the heart, there was no chance to have the infections over the device or vegetation or possibility of infective endocarditis is very rare because it's completely encapsulated inside the heart. And the device length is very short, so it's almost completely inside, like encapsulated. Let's move forward. There is another article which was published in the Journal of Cardiovascular Electrophysiology in 2019. It basically showing with pre-existing infection results for the MICRA post-approval registry. And it shows that they include 105 patients with prior CID infection and they implanted MICRA device or the leadless pacemaker. And they shows that all systems, like in the CID infection patient, they explanted in 93% of the patient the complete components. And the difference between the implantation of the leadless pacemaker as compared to the explantation is around 6 to 7 days. And in 37% of the patients, they implanted a leadless pacemaker on the same day as they explanted the CID because of the infection. And they gave like 90% receive antibiotics preoperatively, 42% receive postoperatively, and 2 days median hospitalization after implantation of the leadless pacemaker. And during the follow-up, there were 2 patients died from the sepsis, but none of them required extraction of the leadless pacemaker for ongoing infection and for ongoing treatment. There is another indication for the implantation of the leadless pacemaker is those patients who need devices, but they are on hemodialysis, because hemodialysis patients are very high risk complication rates and mostly related to the venous access and also the infection. So leadless avoids these complications and remain the higher complication rate compared to the other population. Let's move forward regarding the use of this leadless pacemaker in the cardioinhibitory vasovagal syncope. It was also done and it was published in the International Journal of Cardiology and Heart Vascular in 2019. They basically involved 32 patients who has cardioinhibitory vasovagal syncope from 2015 till 2018. And out of the age almost is around 18 to 64 years and median age was around 37 plus minus 14. Out of them, 62% were female, and each of the patient has 4 to 6 events per year. And they did the follow-up of around more than a year, 1.5 years, and they found that 87% of the patients were free from the symptoms. So this is also a good results regarding the vasovagal syncope. The another data which was published in the Heart Rhythm 2020, and it shows the safety and efficacy of the leadless pacemaker for cardioinhibitory vasovagal syncope as compared to the conventional dual chamber pacemaker. So they basically implanted 28 leadless pacemaker VVI versus 48 conventional, and they found there is no difference in the incidence of subsequent syncope in the patients who underwent leadless pacemaker. Now, there's a talk when to retrieve, when to retrieve or not to retrieve. There's a systemic revision with the MICRA transcatheter pacemakers. So when you have to retrieve, the retrieval should be early. Should be revision occurred within 9 days after the placement and MICRA implanted within 14 days. So 9 to 14 days, we can retrieve the device. The most common reason is acute elevation of the pacing threshold and also the depletion of the battery. Then you can remove within 14 days of the implantation and you can implant a new one, or you can go for the conventional device. Now, let's move forward to the future of the leadless pacemaker. So the future of the leadless pacemaker will be leadless conduction system pacing in the near future. And also there is a leadless pacemaker and subcutaneous ICD, and the leadless cardiac resynchronization therapy, and also self-rechargeable leadless devices. So let's go. There's a first human study which was published in April 27 this year in Heart Rhythm Society. It was with the left bundle branch area pacing with the leadless. And they found that it is safe and electrical performance is acceptable. But this study is depending upon only 14 patients, and out of the 14 patients, only 10 patients were successfully implanted this device. And out of 10 patients, only one patient has successful left bundle capture, and the remaining 4 patients has only ventricular septal pacing. So still we have to move forward, and we need more data regarding the implantation of the leadless pacemaker in the conduction system. The other thing is the defibrillator, leadless pacing defibrillator system. So what we have to do if the patient has ICD and we implanted and patient needs like subcutaneous ICD along with the pacing, so we can put the leadless pacemaker and we can synchronize the leadless pacemaker with the subcutaneous ICD of the same device, which is usually available in the Boston. And this is a study actually done by the Boston Scientific, and it's called Modular ATP Clinical Trial. And it shows in the patient with a sustained monomorphic ventricular tachycardia, 61.3% episodes of the arrhythmias were successfully terminated by ATP delivered by the leadless pacemaker, which is also the future if the patient has recurrent CID infections.
Salman,
The
you have
other
one
thing,
minute, please.
yeah. I think it's the last slide. The other thing is the leadless ultrasound-based cardiac synchronization heart system in the heart failure, which is published in the YCRT system, and it was done in the US, and it involved around 35 patients, and it's showing that out of 35 patients, they have successfully implanted in 30 patients, and the improvement in the ejection fraction was around more than 50%. And it is a new technique which can be done with the leadless as well. So the conclusion of my talk today is increasing level of evidence base surrounding the leadless pacemakers. Currently, most this related to the Micra and Avere, and good evidence of safety and efficacy is available, and emerging clinical indicators for the benefits in specific type of population. So selection of the patient is very important in which patient we have to implant. The patient with the metallic valve, the patient has a recurrent infection of infective endocarditis, the patient with the bioprosthetic tricuspid valve, the patient who has a severe TR, and the patient who are in hemodialysis, or the patient who has previous infective endocarditis and the extraction of the devices. The other thing, further evidence expected related to the new device, which is Empower, which is a Boston device regarding the leadless versus subcutaneous ICD. So, and the future is the physiological pacing with the leadless could be the future. Thank you so much.
Thank you very much, Dr. Salman, for an interesting and comprehensive talk. We will move now to the second speaker, Dr. Hussein Hadu, who is a senior electrophysiologist at King Saud Medical City, and he will talk to us about conduction system pacing in bradycardia and heart failure. Dr. Hussein?
Assalamu alaikum, everyone. Can you see my slide? Hello?
Yes, we can see it, yeah.
Okay.
You can share it now, please.
Okay. I start to share it. Let me go to slideshow. Thank you, Dr. Bender, for the introduction, and thank you, Dr. Fahad, for giving me the opportunity to do this talk for you. I'm going to talk about conduction system pacing in heart failure. I have no disclosure related to this talk. The objectives, I'm going to give you 2 illustrative cases, and I will discuss the role of the conduction system pacing in heart failure and bradyarrhythmia in the light of the recently published document by the ASC, which has been just published March this year. Just to summarize, because sometimes the terminology could be confusing for those who do not do pacing. So when we talk about RV pacing, we are talking about apical pacing, typical apical pacing. The RV lead will be in the apex, and that will be the yellow one, the number 1. When we are talking about biventricular pacing, we are talking about a lead in the coronary sinus, and ideally should be in a lateral branch. And when we are talking about left bundle pacing, we are talking about a lead which is at the basal septal area, and it is deep septal pacing, pacing the left bundle on the left side of the septum. His bundle pacing, like what you see in number 3, labeled number 3, it is uh, implanting the lead at the area of his bundle. And there is combination of these. If we have left bundle lead plus CRT lead, we call this lot CRT, which basically left optimized CRT, left bundle optimized CRT. And hot is basically his bundle plus CRT. So I'm going to start with a case. This is an 85 years old gentleman coming with syncope and shortness of breath, and he has ejection fraction of 55%. I'm sure all of you see the ECG, which is showing 2-to-1 AV block with fascicular block. So option one, he's an old guy, little left with little left should go for single chamber or dual chamber anywhere leads, or dual chamber septal lead or conduction system or CRTB. I'm sure most of you may be going for option 2. One of my old consultants will go for option 1, and I'm sure no one will go for option 5. But if we see the chest X-ray, we can clearly see there is an evidence of infection, evidence of heart failure. I wonder if that's going to change the option here. I'm sure most of you will now think of going for conduction system pacing, but there is little ground really to recommend CRTB, but the other 3 options become increasingly not favorable. So we went for the conduction system pacing, and as you can see, the lead in the LAO view in the right side in the right side is clearly going towards the septum, and in our RAO view it is in the mid-septal area, which is the ideal location for the left bundle pacing. And that's how it looks in the chest X-ray. And that's the ECG both implant, and you can clearly see now we have a nice neurocomplex with R prime in V1, and as I written here, even the fascicular block has now been corrected, which is nice left bundle pacing result. And this tell us that even in elderly people who have distorted sometimes anatomy and may not tolerate long procedure, it is feasible to go for left bundle pacing. And this patient has been seen recently in follow-up and he's doing very well. This is an ECG from 2022 for the same patient, and you can clearly see here he has left anterior fascicular block, which has been corrected here by left bundle pacing. So conduction system pacing in bradyarrhythmia, it is well established, and actually this is an European survey, and you can see clearly here, even in patients with normal ejection fraction, most of the physician will go for conduction system pacing, either left bundle or his bundle pacing, and less than 30% only has been using RV pacing. I'm not sure how accurate is that, because sometimes in Europe, sometimes they just want to say the things that people expecting them to say. When you come to AF ablation, you find even less percentage going for RV pacing, less than 15%. So this is my approach to the brady pacing regarding conduction system pacing. You can see even in sick sinus syndrome, where you do not expect to have LV dysfunction, conduction system pacing is an option here. Especially there's a growing evidence that when you do RV pacing in people with sick sinus, although these people most of the time you can get away with pacing the atrium, you increase the risk of having atrial fibrillation. So conduction system pacing is a better option in this patient. In AV block, conduction system pacing is an option for everyone, and it is increasingly important to consider when you have a patient with expected high pacing burden and those who have impaired LV function. In this type of patient, conduction system pacing is increasingly become the first choice, especially if we compare the cost to the biventricular pacing, which is the second option. It is much cheaper to go for conduction system pacing. So apart from those with normal left ventricular ejection fraction and less predicted LV pacing, the conduction system pacing should be really the norm in this type of patient. The third group of patients is those who are AF patient requiring AV node ablation, which is basically base ablate therapy for AF patient, which is gaining a lot of ground due to good outcome in this patient. Here again, you can see the conduction system pacing is increasingly the main option. And apart from those who have normal ejection fraction, almost every one of these patients will be better off having conduction system pacing. And I can see this is going to be the dominant type of pacing in the future for this group of patients. The evidence we have, there is two statements. One has been published by multi-society in 2023, including the HRS. And the most recent one is the one published by the ASC, which has been just published in March. And it is giving more support now for conduction system pacing. You can see across the indication, although it looks a little bit complicated, but across the type of patient, you will hardly find RV pacing is a choice, except in those who have less percentage of pacing and normal ejection fraction with high burden of pacing, which is honestly, I don't think normal ejection fraction with high anticipated level of pacing should really make you go for RV pacing. I have seen a lot of patients, and I'm sure a lot of you have seen patients with starting with normal ejection fraction at the start of implant, and few months down the line or years down the line, they develop heart failure due to pacemaker-induced heart failure. So the evidence for the pacing in patient with AV block is increasingly become conduction system pacing more than RV pacing, with little ground for the CRT as well. As I said, in AV nodal pacing, in AV nodal ablation for patients with atrial fibrillation, you can see RV pacing only for those who have ejection fraction more than 50%. And across the board, the conduction system pacing become the option, with BiV becoming more stronger in those who have an ejection fraction below 40%. Let us move to the second case, which is basically to illustrate the type of patient we see with heart failure who can be a good candidate for conduction system pacing. This is a 40 years old lady. Actually, she's a very recent patient. We have discharged her a few weeks ago. She's non-heart failure with biventricular failure, ejection fraction 20%, coming with sudden onset of severe shortness of breath. And as you may see, she has ventricular tachycardia, which looks coming from the lateral wall, negative in lead 1 and AVL. So it is most likely coming from the higher lateral wall, especially if we look at V6 is positive. And this in itself make biventricular pacing less attractive, because when you see an ECG like this, you would know that the scar is most likely in the lateral wall, where you are going to target by the biventricular pacing. So it has become a less an option in this type of patient. When we cultivate her, the ECG here showing most likely atrial fibrillation with AV block, because we cannot see any P wave, and it's clearly neurocomplex. So she's having AV block with scabrysm. Most likely the scabrysm is suprahesion because it has neurocomplex, which indicating that the downstream conduction system is good, but the AV node is diseased. And this heart chest X-ray, as you can see, bilateral pleural effusion, cardiac MRI showing severe biventricular failure with ejection fraction 24% of the left ventricle, severe biatrial dilatation, more in the right side, as you can see in the image provided, severe mitral regale and severe tricuspid regale. And it was showing mid-myocardial enhancement, which suggesting this patient has non-ischemic cardiomyopathy. And the course of this patient, she stayed in hospital for 40 days, requiring actually bilateral chest drain to drain the pleural effusion because she was very resistant to diuretics. Actually, we have to ask the family to see if they can bring furosemide because she wasn't responding to IV furosemide high dose. And she required temporary pacing wire because she keep going into ventricular tachycardia with the background of AV block. So whenever we give her antiarrhythmic medications, she go very brady and hypotensive. So we have to put a temporary pacing wire because at that time she was not stable enough to have pacing device. And after almost 1 month or 35 days, she became stable enough to go for a device. So the options here, CRTB, this was actually argued for by the heart failure team because they think that she is maybe end stage heart failure and maybe giving her ICD is not really a good option. CRTD, this is what we argued for, the electrophysiology team. I argued for because I don't see the rule of 1 year applicable to those who have secondary prevention. For primary, yes, we want to see or we want to know that they, or have expected life of 1 year for the patient. So we were thinking of CRTD as an option to go for LOT CRTB or hot CRTB or CRTD. And the other option is conduction system pacing only and forget about the ICD. So we, after lengthy discussion, decided she's young. We need to give her time. She has very good quality of life before admission. And this deterioration is most likely related to ventricular tachycardia. So better to give her a chance after being stable to go for CRTD. During procedure, she has silent right atrium, no any electrical activity. This is the second case in my life to see a patient with no any electrical activity in the atrium. I implanted the atrial lead in multiple locations and never seen any electrical activity. There was a very tough CS valve, which was not allowing me to pass the lead across. I was able to go by angioplasty wire, but even with that, and even using microcatheters, the one which used by our intervention guy, I was not able to go through that valve. And the middle cardiac vein was just at the os, and I can show you the picture here. You can see clearly the valve at the tip of my CS sheath, and you can only see another branch away from the valve. I was able to get to that branch, but it was very anterior. And you can see clearly in the image on the right, even the angioplasty wire is not going through that valve. So we have little option really here. And I'm glad at the start of the procedure, I was able to put the lead, this defibrillator lead, in a very basal location. And it was actually giving me a very nice narrow complex. And as you can see, similar to that patient, there is R prime, narrow complex, the bifascicular block, which we have, the anterior fascicular block, which we have been seeing in the initial ECG disappeared. The QR is a bit wider if you look at the inferior leads, but I think that's reflecting the disease of the patient. That lady has a very diseased biventricles. So not surprisingly, she will have not an ideal neurocomplex, but this is a very good left bundle pacing using the defibrillator lead, which is very good for this patient because to be honest, I can see even if I manage to go through the coronary sinus, I will end up putting the lead in scarred area, and I may not have a benefit from that LV lead and may even induce arrhythmia in this patient.
1 minute, Dr. Hassan, please.
Okay. So the MRI significantly reduced both the implant, chest drain removed next day, post procedure, discharge 3 days, post procedure, and seen in follow-up and doing very well. And I can show you the echo briefly. This is pre-procedure and this after procedure, and you can see the function is a little bit improved. Here, the second image showing you the MR pre-procedure on the left and the MR post-procedure, which is significantly reduced as well. So for heart failure, the options is very easy. If the patient need a new implant and he has ECG showing left bundle with or interventional conduction delay, CRT is better option than conduction system and has more body of evidence to support that. Right bundle branch block, definitely conduction system carry more weight than the CRT. On those who have pre-existing device, you can see clearly conduction system have an upper edge apart from the pacemaker-induced heart failure where they are equal. The CRT and conduction system have equal evidence. And for non-responder for CRT, then LB lead or his bundle lead is a very good option. And this is the supported by the ACS statement. And in my view, the conduction system basing gaining more ground. It is not competitive to me. I think it is more complementary than competitive. And to conclude, conduction system established option with clear guidelines for brad pacing. The new AAC consensus statement supports the use for conduction system pacing as alternative or complementary to CRT. It may become the main mode of pacing, as I mentioned, for AF patient who require AV node ablation. The issue is still we don't have a dedicated lead or device for this type of pacing. We're still using the pre-existing devices, which we normally use for other options. Thank you very much.
Thank you very much, Dr. Hussein, for insightful talk. We'll move now to Dr. Raed Swaidan, who is a pioneer cardiac electrophysiologist in the kingdom, and he is from King Fahd Armed Forces Hospital. He will talk to us about extravascular and subcutaneous defibrillators. Dr. Raed?
Thank you. Can you see my slides?
Not yet.
Not yet. Okay. Okay. How about now?
Yes, yeah, I can see it.
All right. Thank you very much, Dr. Bender, and thanks for Dr. Fahd for the invitation. So my task actually is to talk about the subcutaneous and the extravascular ICDs and indications and long-term outcome. And those are my disclosures. Now, this is my objective actually to why do we need the non-vascular ICDs? And talk about the available non-vascular system, which are the SICD from Boston Scientific and the EVICD from Medtronic. We'll talk about the clinical evidence, safety and efficacy and their limitations. We'll talk about, in particular, inappropriate shocks and infections as compared to the regular transvenous systems, and then the appropriate candidates for those non-vascular systems, and I'll finish with the current guidelines. So we have used the transvenous system for a long time. They work, they save lives, but we do face challenges, and mainly those are challenges due to the leads themselves. They fail over time, and when you try to revise them, you get the risk of infection, and once you get an infection and you need to remove the device and the leads, there's a significant morbidity and mortality associated with the lead and device extraction. So if you look at statistics, over 10 years, about 1/3 of the ICD and CRT leads will actually fail, whether mechanical or infection. And once you open the pocket for revision, you increase significantly the risk of infection. And once you go into extraction, the mortality associated with extraction or the mortality after extraction, if you only have an infected ICD lead, it's 12%. And once you have an endovascular infection, endocarditis, the mortality in 1 year is almost 30%. So there is significant morbidity and mortality associated with those lead complications, which makes sense not to put the leads intravascularly. So we have currently two systems, the Boston Scientific SICD, where the lead is placed under the skin and the device lateral chest, and the extravascular ICD from Medtronic, where the lead is actually placed underneath the sternum and the device is at the lateral chest. If we want to compare those two systems, the device from the Boston, the SICD, is double the size of the EV-ICD from Medtronic. And that's basically because the lead, the defibrillator lead for the EV-ICD sits underneath the sternum, and therefore it has a lower defibrillation threshold, and therefore the battery would be smaller, and the longevity is actually higher because you don't need such energy to defibrillate, similar to the SICD. So the lead in the SICD is subcutaneous. In the EV-ICD is under the sternum. As I mentioned, the defibrillation thresholds are lower with the EV-ICD compared to the SICD. Now, there is a screening to assess for T-wave oversensing before you implant the SICD. You don't need ECG screening for the EV-ICD, but chest CT is probably reasonable to check the anatomy, the sternum, the xiphoid, and the position, and the on the right atrium, especially as it goes into the midline. Fluoroscopy, you don't need a lot of fluoroscopy for SICD implant. However, it's significant for the EV-ICD. And of course, the SICD is a non-invasive procedure. For the EV-ICD, it's more invasive since you're going to try to get the lead under the sternum. And because of the lower need for energy, the longevity of the EV-ICD is much higher than the SICD. So the SICD history started in the year 2000 with multiple studies that showed the feasibility and then the safety and efficacy of this procedure, leading from the first generation to the second and currently the third generation, which has two-zone programming and also an algorithm to reduce T-wave oversensing. I have to say that the size of the SICD was reduced a little bit only from the first to the third generation and became a little bit thinner, but still quite a big device. If you look at the clinical data, this is the post-approval study of the SICD system. This is a prospective registry looking at more than 1,600 patients with a mean follow-up of over 4 years. And the efficacy for shock success is actually very good, over 98%, and safety with a complication-free rate of actually better than 93.4%. So efficacy and safety performance actually was good and met the goal for this safety and efficacy for those studies. This is a meta-analysis for all 5 randomized clinical trials that actually compared the SICD to the transvenous ICD system. It's over 2,300 patients, and they found out that the SICD and the transvenous ICD system have similar rate of device and system-related complications. The SICD has significantly lower lead-related complications, where the SICD had a higher non-lead related complications, mostly related to pocket infection and hematomas. Both systems, SICD and TV-ICD, has similar rates for inappropriate and appropriate shocks and similar mortality. This is a recently published extended follow-up of the Praetorian trial. This is a trial that looked at comparing SICD versus the TV-ICD. And this follow-up was extended to 7 years. And this was published recently, last month actually, and presented in the recent HRS meeting. And there was no difference in all device-related complications, major and minor, between the two devices when look at intention to treat analysis. The TV-ICD patient had more major complications or lead-related complications compared to the SICD. And if you look at as treated analysis, the complications were much more significant with the TV-ICDs compared to the subcutaneous ICD. If you look at the inappropriate shocks, and as with every technology, you start with really high inappropriate shocks and goes down as we improve our programming, and also in the case of the SICD, improve the software to decrease the T-wave oversensing. So as we go into the most recent trials, you can see that the inappropriate shock rate in around 4% for both SICD and transvenous ICD. So the inappropriate shocks have come down for the SICD to similar rates close to the transvenous system. So who are the good candidates? Of course, if you have somebody who had a CRT indication or Brady indication or known to have monomorphic VT and needs ATP or fails screening for the T-wave oversensing, you have to give them, unfortunately, transvenous ICD. But if they have no venous access, either because of occluded veins or congenital disease, or they are at an increased risk for infection, like a chronic kidney disease patient on hemodialysis, or immunosuppressed patient, or prosthetic valve patient, or prior infections, or even you can make case for young patients who actually going to have the device for a long time, and most of them, they have, their arrhythmia is most probably going to be polymorphic VT or VF in channelopathies. They do not require pacing, and those are very good candidates for subcutaneous or non-vascular ICDs. So if you think about it, with the results of those trials, why not an SICD for all ICD candidates who would not have an indication for pacing and who would pass the ECG screening? If you look at those type of patients, actually 60% of primary and secondary prevention ICD candidates will be eligible for an SICD. But if you look at the penetration, it's still very low, less than 10% from the total ICD volume. And you can look for many reasons that actually people don't pick the SICD, maybe because it's a large device, reduced battery longevity, larger or longer procedure time, or the need for heavy sedation or general anesthesia, maybe the cost. And if you look at the guidelines, it's still a class 2A recommendation as an alternative to transvenous system. Those are things that you can think of why people don't do the SICD, despite actually we are having growing evidence for being non-inferior to the transvenous one. As mentioned earlier in the talks, now we have a modular system where the SICD is married to a leadless pacemaker, and there's like one-way communication from the SICD to the leadless pacemaker, by which this leadless pacemaker can provide anti-tachycardia pacing and backup bradycardia pacing in conjunction with the defibrillation provided by the SICD. This is the modular ATP trial. The complication-free rate was excellent at 97.5%. Communication was almost 99% between the two devices. And ATP success in terminating ventricular tachycardia was around 61%. So moving now to the new kid in the plot, which is the Medtronic Aurora extravascular ICD system. In this case, the lead is placed underneath the sternum, and putting the lead underneath the sternum give you two advantages: allow pacing and reduce DFT. Now, the lead can provide anti-tachycardia pacing, post-shock pacing, and post-prevention pacing. But this device is not intended for brady pacing because it's very uncomfortable to have pacing for bradycardia, and that will deplete the battery very, very quickly. Because of the low defibrillation threshold, we're actually using a device that is similar in size and shape like the transvenous system devices and has a better longevity than the SICD, almost 12 years now. Again, for the Medtronic journey with the EV-ICD started in the year 2012, eventually leading to the pivotal trial that was published in October 2022. And on those trials, we have up to 400 patients in many centers with multiple implanters. The pivotal trial basically looked at the safety and efficacy of the EV-ICD in high risk in patients who are at risk of sudden death. Around 316 patients with follow-up of 6 months, classical indications for ICD implantation. The people who were excluded, any indication for pacing, and if any sternotomy surgery has been performed before, this is a contraindication. The defibrillation efficacy was excellent at 98%, 98.7%, and there was no statistical difference according to BMI. And even the chronic defibrillation threshold after 6 months was excellent, 100% success. And all cases clinically that occurred during the follow-up of 10 months were successfully terminated with defibrillated successfully. If you look at the safety endpoint, was also met, almost 93% freedom of system or procedure-related complications. Interestingly, there were no major intra-procedure complications or procedures or complications unique to the EV-ICD. The 7% event rate was related mainly to either dislodgement or hematoma or infection at the generator site. Importantly, there were no reports of mediastinitis, sepsis, or endocarditis related to the EV-ICD. If we talk about the ATP performance, the success rate in terminating VT were around 67%. And the interesting thing is that the acceptance for the ATP increased over time. So at implant, 66.8% were programmed on, and after 12 months, almost 80% of the patient had the ATP turned on. And a very small percentage of patients, actually 3.6%, had to turn off ATP at 12 months due to the discomfort or painful sensation. If we talk about the inappropriate shocks with the EV-ICD, the yearly incidence is around 10%. And again, this is high, but this is early technology, and they are coming down. Most of the inappropriate shocks are due to cardiac signals, mainly P-wave oversensing. And with the changing in the procedure technique and the development of the P-wave oversensing algorithm, when they retrospectively apply this algorithm to the inappropriate shocks that were seen before, there was a 42% reduction in inappropriate shocks. So that would help reduce inappropriate shocks with this system. This is the 3-year follow-up for the pivotal trial and actually emphasized what we saw earlier before. So the ATP usage significantly increased from discharge to last follow-up. The ATP was successful in 77% of episodes of ventricular tachycardia. Appropriate shocks therapy was successful in all cases. The inappropriate shocks at 1 year was around 10%, and at 3 years was 17.5%. The P-wave oversensing was the predominant cause for inappropriate shocks. Freedom of major complications was around 92 at 1 year and 89 at 3 years. And the most common complication, as I alluded before, dislodgement or wound infection or hematoma at the site of the pulse generator. If we look at the most recent guidelines, and I'll talk about the ASC guidelines, we don't have guidelines for the EV-ICD because it's a new therapy and it's not covered by the most recent guidelines, which looked at the SICD, and it's a class 2A indication as an alternative to implantation of a transvenous system. So I suspect in the future, with the data that we have, the non-inferiority, but also less lead-related complication, that the level of evidence is good enough to actually elevate the indication for non-vascular ICDs in the future.
1 minute, Dr. Raed.
Yeah, so I'm here concluding. The transvenous ICD lead complications are common, and they are associated with increased morbidity and mortality. The lead-related complication of the transvenous ICD system can be significantly reduced by the non-vascular systems. The SICD is safe, effective, and is not inferior to the transvenous ICD systems. I think the only problem with that is that this system does not provide ATP or bradycardia support. Now, although the EV-ICD seemed to be invasive with the placement of the lead under the sternum, however, the data showed this is safe and effective and has the advantage of a smaller device with a better battery longevity, in addition to providing anti-tachycardia pacing and pause prevention. I think the future of ICD guidelines should probably reflect the increased role of the non-vascular ICDs and should elevate the level of their recommendation. And I'll stop here. Thank you very much.
Thank you very much, Dr. Raed, for comprehensive and interesting talk. Last but not least, our speaker now is Dr. Lamia Shangiti, who is a known cardiac electrophysiologist from Prince Sultan Cardiac Center. And she will talk to us about value of remote monitoring in the cardiac implantable electronic devices Saudi Arabia experience. Dr. Lamia?
Assalamu alaikum, everyone. First, I would thank for an invitation regarding this talk. And special thanks also to Dr. Fahd al-Mahmadi for arranging this, and also for Dr. Ahmed al-Faqih, who started kind of going over the remote monitoring, and I had a lot of help for him preparing for this talk. So I'm going to start with my talk regarding remote monitoring. So I'm not sure if you're able to see my screen.
Yes, yeah, we can see it.
Okay. So as we know, cardiac implantable devices is kind of relatively new regarding the medical field. It started in the 1970s, and with that we had special programming to be able to program the devices. So in the 1980s and 1990s, we had those multiple Medtronic programming. So the first programmer was around, it's only able to test the pulse width and the pulse width and the pulse rate for the devices, mainly pacemaker. And in the late 80s, we were able to get the fully, truly programmable devices that is actually portable, so you could take it from one place to another place. The older devices had to be hooked into an output and had limited functions. In the early 2000s, we started having the current programmer. Mainly, those are the Medtronic programmer. And more recently, we started having the tablet size programmer that were able to interrogate and program the devices. For the time being, we're not able to get any remote programming for the devices, as it's still kind of security-wise is not very feasible. So as we know, the more implants we have, the more time we need to manage the patient, and we need more time to reassess them. And sometimes we're going to have difficulty managing all those patients within the clinic time. So this is our data for the last 10, 15 years. So over the last 15 years, we implanted around 2,000 pacemaker devices, around 3,000 plus ICDs and CRTs, and more than 500 ILR. So for the time being, so those are the pacemaker implants. There was a dip within the kind of 2016, 2017, and we almost plateaued within the last 5 to 6 years. For the ICD and CRT, probably early in the 2010s, we had a higher increase in ICD implantation CRT, but with the expansion of the EP centers and the cardiac centers, kind of there was a diversity, or kind of the implant has kind of dipped down until the 2024 of last year. So similar, there was an up and down slope for the ILR implant. So the last year we reached almost around 80 cases, but it's kind of ranging between 10 and 50 or 60 in average almost. So those are our data for the device clinics visits since 2010. And we see kind of the more implants we had over the last few years, we have an increase in device visits. So that's kind of for all devices, whether it's pacemaker, ILRs, or high voltage devices. So within the 2019, 18, 19, we started implementing the remote monitoring for our devices. And with that, you could see there is a dip in the in-clinic visits in 2019. So less than 5,000 patients were followed in our clinic in 2019, which with that, we had increased our numbers for the remote monitoring. So for the last 5 years, we had significantly increased our numbers for the remote follow-up. So 2020 might not be a good indicator given the corona pandemic, and their access to medical care has been limited. But with here, we had really increased our clinic remote monitoring follow-up. So we had a very good program with Medtronic that they were able to provide us with a high number of remote monitoring devices, mainly CareLink devices, so we're able to get the patients enrolled as safely and kind of readdress their concerns if needed. So after the corona pandemic, I guess there was kind of maybe a fear of the patient that they lost the clinical touch with the physician. So we had an increase in the inpatient clinic follow-up and a dip in the remote monitoring follow-up. But as the year progressed, we found that patients are more comfortable getting their devices monitored remotely, but still some clinic visitors required for further managing the patients, whether heart failure or kind of other coronary artery disease related in clinic follow-up, which we have seen that there is a trend towards increased patients follow-up. So sometimes they even come to the clinic without having to pass by the device clinic for check because they have been reassured. So for remote monitoring for high voltage devices, it seems that it's been giving us the equivalent information obtained from in-clinic visits. So we're having to able to check for the arrhythmias, shock, device function, and battery status, and all schedule interval or when triggered by event. So as I said previously, unfortunately, we don't have any therapeutic capabilities. So any device programming really requires the patient to visit nearest CIED clinic or even our clinic for reprogramming of the device. So for overall kind of looking up at the mean follow-up for 5 RCTs trial, they showed there is no significant difference between groups who had appropriate shock or inappropriate, whether they were remotely followed or no. I guess also that has to do with the need for reprogram the device to minimize the inappropriate shock. But kind of regardless, the patient would have to come to the clinic or to the emergency room for assessment and monitoring the device and establishing medication. But overall, there seems to be decreased event rate or decreased interference, especially if it has been appropriate, and it still favors remote monitoring. The same thing goes for heart failure, although there seems to be no significant difference between heart failure hospitalization, but it also seems that there is a trend towards remote monitoring for early detection of heart failure and volume overload in such patients. Unfortunately for us, we still haven't had any good collaboration with our heart function team just to be able to increase the follow-up for those selected patients. So for that, I think we should be able to kind of combine them into a mixed clinic for the heart failure function. So whenever we have a high alert, that we're able to refer them to the heart function clinic so they're able to minimize their hospital visits. So, so overall, it doesn't, remote monitoring seems to trend towards favoring for all-cause mortality, but we need further data towards that. In our center, we currently have almost 1,000 patients on remote monitoring. The majority of them, around 700, 800, are in the Medtronic devices. Over the last few years, we have been increasing our Abbott remote monitoring. We have almost 155 devices now with remote monitoring. So it's not that kind of we prefer one company regarding the other, but we seem to have an early enrollment with the Medtronic patients for the remote monitoring. So for the Medtronic, there are 2 areas of remote monitoring that we could enroll our patients on. So the CureLink and the Focus On. So the Focus On is mainly used for our ILR patients, and kind of hopefully there is an integrated system that we have turned on that notification. It will alert our triggers monitoring and alert an event, and it will be transmitted to our CIED clinic staff for further action. So we have more time. We have less time spent in reviewing the event and more time for treating patients. We have able to prioritize and proactive communication, free up resources. We're able to enable better outcome, especially if we have something triggers like atrial fibrillation or kind of causes that might cause further harm to the patient. So these are kind of the red alerts that is getting released by the Medtronic Focus On. So we usually have the alert within 2 hours that we have been notified either by phone or by email. So the Amber usually is notified by email, and weekly that means that we have good data and good connectivity, just kind of to ensure proper follow-up for these patients. So the red alerts is usually if there is any significant tachyarrhythmia, significant pauses, bradycardia, atrial tachycardia, or atrial fibrillation. The non-acute, if there is bradycardia, or if there is successive AT or AFib. The green, there hasn't been any significant issues, or there might be, or if you want to kind of alert for atrial tachycardia or atrial fibrillation burden. So we've noticed that in our clinic, the majority, let's say there's kind of a split between syncope and cryptogenic stroke. So we have a low threshold for implanting ILR in cryptogenic stroke. And with that, we were able to detect a good number of patients who had either atrial fibrillation. And I think around 30 or 35% of our cryptogenic stroke turned out to have atrial fibrillation and started on proper anticoagulation. So some of them has been for detection in AF burden, and around 20% for palpitations, for something we're not able to detect on a event monitor, such as extended patches or extended Holter monitor. So with the virtual clinics, so initially we had the curling system that is installed at the patient's home. And we have established hotline communication with an on-call team to be able to get in contact with the patient, or the patient get in contact with them for any events or alarms, or if there is any significant. And we initially started it with a patient who's been outside of Riyadh, and then now we're expanding it for any patients who has remote monitoring capable device. So for kind of the devices that are the challenges that we're having now with the remote monitoring is the data security and the data accuracy. And some of the companies were having issues with providing remote monitoring logistics, just kind of contract and availability of remote monitoring devices, and real-time access to data. So there has been some delay in data transmission, but is kind of being kind of hopefully addressed in time. And last but not least is the cost of the service. So currently, given the tablet availability, or the tablet availability for the smartphone or smart tablets, the app, we're able to reduce the cost significantly, especially with the careling devices that has been usually shipped to the patient, and sometimes it's the same cost as the device itself. So we get to the patients and kind of try to get their perspective. Why do we need remote monitoring? How safe it is to protect their data, and who's responsible for protecting and collecting, and if the patient is able to access their data, and who is the person available in contact, and also issues about disconnection for bedside monitors or even handheld devices. So for sorry, for Medtronic, they have the app, which is My CareLink Heart. So it's available for a variety of handheld devices, Apple, Samsung, Galaxy. So, and it's been easily accessible. So kind of the device is usually paired with a smartphone, and that will be automatically connected with the CareLink network. So all the patient has to do, install the app, and it's usually there is a good rapport between the patients and our clinical staff that kind of once the device is implanted, at the same time, we usually enroll them within the CareLink system. And the clinical staff goes with the enrollment algorithm with the patient just to make sure that everything is good. So they have to enter their information kind of within the system, and they have to enter their serial number, which is provided by our in-clinic staff or our implant technician. And after that, verifying the email, and overall, they have a successful implant. So it's probably around 10 steps total, but usually goes well within 5 minutes and you're having good connectivity. So once the patient is connected, they're kind of giving them any kind of information about the battery status, if there is any alerts will come to the patient's app. And if they're having any symptoms, they could track their symptoms and send any alerts to the clinic for further analysis. So for the Apple devices, they have the Merlin.com, which is a similar application. So it's also compatible with all the newer smartphones and even tablets. So the same thing is kind of download the device within my Merlin.com, and you pair it with the, has to be within 3 meters of the device, and then connected by Bluetooth or wireless. And after that, enter the patient's information, serial number on the device, and that will enroll the patients in the app. So we have around 25% of our patients now have been app-based remote monitoring, whether they're patients or a caregiver with the patients. So our hope is kind of later on in our clinic to be able to integrate it into our pacemaker analysis software, so we don't have to visually kind of or enter it manually for further follow-up. And we're usually having a good action plan within the weekdays, is kind of if there is any kind of amber alerts, it's usually within the weekdays that it's less than 48 hours, or usually within less than 24 hours. And the weekends kind of takes a little bit of a longer time to be able to get a full staffing into the clinic. And we're having increased almost 25% numbers of transmissions since we started that. So with the newer programming, the tablet space has been easier also to integrate the remote monitoring for our patients. Kind of has been easy, accessible. You could mobilize it everywhere with you, especially with the CareLink Express mobile application. We have been using that also sometimes in our emergency department, especially if someone comes in with shock or kind of has any doesn't have any remote monitoring available. So we've been using the CareLink Express mobile. So it's a portable with a handheld device, and you're able to get a full analysis of the device without having to have a programmer available and someone who's expertise. And the access to it, the report comes in a PDF format, so you're able to see and judge accordingly. So we're hoping that we're able to expand the CareLink mobile application across outside of Riyadh, so we'll be able to minimize the ER visits all the way to our emergency for just a device check. What we're hoping also is to get a universal platform. So this is a platform from Implicity. I think it's a US-based company that's able to connect all kind of different devices, Abbott, Biotronic, Boston, Medtronic, and get it into a web-based system, so that you don't have to um, open each company's website, whether it's Merlin.com or CareLink.com, to be able to check. So this hopefully website will get you all the data, all the information of the patient in one system, and be able to look into kind of the alerts, and you're able to get action into the alerts, and also schedule patients for follow-up through a one system. And kind of that will simplify the workflow in the clinic, hopefully. So in order to establish a good remote,
You are running out of time, please, if you can conclude.
yes. So for the remote monitoring, this is the Heart Rhythm Society calculator, just to see how we're able to manage our system better. So we need to get the number of patients, ICD, pacemaker, ICD or CRT and IRLR patients, and establish how many full-time employee hours per week and week per year, and just to be able to calculate the staff meeting. So the take-home message from the Heart Rhythm Society is that for patients with cardiovascular implantable devices, remote monitoring is the standard of care. So hopefully that will increase regular connectivity and long-term adherence with remote monitoring. And we need especially adequate staffing who has both clinical and non-clinical personnel with able to communicate with the patients and the caregivers. I'll just kind of here, we'll have to kind of go to, especially I'll try to establish an alert-based remote monitoring so that we're able to define who's the patient, what is the alert that it should be announced to the patient and now to us, whether we need arrhythmia detection or heart failure detection, and that will be based on individual patients. And that will be it. Thank you very much.
Thank you, Dr. Alema, for interesting talk and for sharing your experience with remote monitoring. We are running out of time, but we will try to take one or two quick questions. So there is a question here, I think, for Dr. Hussein. What are the tips and tricks to implant ICD lead as lift bundle pacing? And is there a need to do DFT, defibrillation threshold testing?
Very good question. Regarding the defibrillation testing, I have done this a second case. I use the ICD lead in the left bundle location. The first patient actually has an event and was successfully defibrillated by the device. I don't do defibrillation testing, to be honest, and I think it should be okay because especially with the left bundle pacing, you are inside the RV and there are likely to be failure of shock. Regarding tips and tricks, I normally shape my stylet like the C315 sheet by Medtronic for the his bundle pacing. And I use the LO view and I target the area between 2 to 3 o'clock in the LAO view. Most of the time, I succeed in get the left bundle pacing at that location. But in addition to that, I use the other features. You need to look for the W shape of the V when you are starting to pacing, and the more deep you go, it should start to give you narrower complexes with a shorter left ventricular activation time and R prime in V1B. The problem with the LV lead is very stiff, especially the Medtronic one. So it is difficult to be emulated. So if the patient have distorted anatomy or previous procedure, is going to be challenging. And as you know, it is not designed for left bundle pacing.
Thank you, Dr. Hussein. The next question is for Dr. Raed. Who is the best candidate for EV-ICD?
So I think if the EV-ICD, I would use it for patients who, number one, has an increased risk for infection, and I don't want to put the transvenous leads in, but also who actually requires, possibly would require anti-tachycardia pacing. So somebody with possibly known to have monomorphic VT that he would require anti-tachycardia pacing. that would be a good candidate for EV-ICD. The other thing is the fact that the device is smaller and had a longer longevity. It's actually, for the long term, it would be actually suitable for younger patients. The difficulty is actually if you have somebody with sternotomy, you cannot put this device. But anybody who you think would require anti-tachycardia pacing and high risk for infection, I would go for that device.
Thank you, Dr. Raed. For Dr. Salman, is there a future for leadless CRT?
Yeah, actually, there are ongoing trials that basically going with the YCRT trial that I already mentioned in my talk. Is basically we are putting like one electrode in the LV and it will sense by the ultrasonic wave and it can contract the LV and the RV at the same time. So we can put like leadless pacemaker in the RV and the electrode in the LV, and there is a transducer which basically sense the ultrasonic wave and it can pace LV and RV at the same time. But it still is in the research process.
Thank you very much. I think because we're out of time, we will conclude here. Thank you very much for joining us to this insightful webinar on advances in cardiac implantable device therapy. I'd like to thank the speakers for their great talks, and it was very interesting and insightful. I'd like to thank Dr. Fahad Al-Ahmadi, Dr. Adil Tash, and National Heart Center team. Thank you also for Nose Tash, and hope to see you soon in another webinar. Wassalamu alaikum wa rahmatullahi wa barakatuh.